Good afternoon and welcome to UCI Mind's Ask the Doc, where live viewers have the opportunity to ask questions of experts in Alzheimer's disease and dementia research. My name is Josh Grill. I'm the director of the Institute for Memory Impairments and Neurological Disorders, UCI Mind, and I will host today's session with my friend and colleague, UCI neurologist, Dr. Gabby Tai. I'm grateful to Dr. Tai for joining me today. Dr. Tai was and is an investigator in clinical trials of the drug that will be the subject of today's episode, aducanumab or Aduhelm. While we wait for Dr. Tai to join us, I'll just set the stage. Welcome, Dr. Tai, for today's session. Today marks an exciting day in the area of Alzheimer's disease and dementia research and Alzheimer's disease and dementia clinical care. We have had a first FDA approval in more than 18 years of a new treatment for Alzheimer's disease. And we are going to be taking your questions about that new treatment, aducanumab, brand name Aduhelm, in today's session. This session is intended for our larger UCI Mind community of patients, caregivers, research participants, advocates, and other scientists. And before we take questions from our audience via the various channels on which this session is being broadcast, I wanted to set the stage by first answering three questions for you. The first question is, what is aducanumab? The second is, what clinical trials have been done for aducanumab? And the third is, how did the FDA make the decision to approve aducanumab? And then we'll open it up, and Dr. Tai and I will be happy to answer your questions. So first, what is aducanumab? Aducanumab is a monoclonal antibody that binds to soluble and fibrillar forms of beta amyloid, the protein that accumulates in the brain of a person with Alzheimer's disease. This particular treatment is infused directly into the bloodstream by slow injection into a vein in the arm once a month. What clinical trials have been done of aducanumab? There have been several clinical trials of this treatment. The first was a phase 1b study that made major waves in the field, was published in the journal Nature, even had the cover of Nature. It was very exciting and promising, showing a dose-related response to treatment whereby brain amyloid levels were lowered in patients who got aducanumab. After this, the sponsor, Biogen, launched two parallel phase 3 clinical trials, the last phase of drug development before a treatment is potentially approved by the FDA. Those trials, 301 and 302, or they were also called Engage and Emerge, and in fact, UCI Mind was a site for the Emerge study, and Dr. Tai is the site PI for that study. Those studies were actually stopped early. There was something called an interim analysis of those studies. And the sponsor, Biogen, concluded that those trials were not likely to demonstrate that aducanumab was an effective therapy, and they therefore stopped those studies. Subsequently, they continued to analyze the data, and they discovered that one of those studies actually was positive and suggested a benefit of aducanumab compared to placebo. The other was negative. Based on those data, and the totality of data for aducanumab, Biogen decided to submit for approval to the FDA last year in 2020. And on the basis of that application, the FDA convened what's known as an advisory committee in November to weigh the evidence. Now, that advisory committee actually voted against approval of aducanumab on the basis that the advisors did not feel adequate data was present to support the clinical efficacy of aducanumab. The FDA weighed this evidence. They actually took extra time to weigh the evidence, and in June 7th, just 2 weeks ago, the FDA approved aducanumab for the treatment of Alzheimer's disease. Now, that approval was through a unique pathway known as the accelerated approval pathway. The approval was on the basis that aducanumab had been shown to lower brain amyloid levels. So they were using brain amyloid measures as what's known as a surrogate outcome. The approval did not indicate that the drug had been shown to have clinical benefit. Instead, that there was reasonable evidence to suggest that by lowering the surrogate, a clinical benefit could also be expected. But as part of this approval through this pathway, the sponsor Biogen is obligated to do an additional, what we call a post-approval clinical trial, to confirm the clinical efficacy of this drug. So where do we go from here? We've got a new approved therapy. The approval is for lowering brain amyloid levels in people with Alzheimer's disease. There will need to be another clinical trial, but now this drug will be available. So that's where we are now. And with that, I'm more than happy to welcome Dr. Tai and to take questions from our larger community interested in obviously a very important and exciting topic. So Dr. Tai, thanks for joining me to do this session. The first question has already come in, and I'm going to give it to you. What's the first step to see if a person is a good candidate to be treated with Aduhelm or aducanumab?
Thank you, Josh, and hello, everyone. The first question came in, what to see if I'm a good candidate for Aduhelm? And I'm going to combine that with the second question. Is this drug only approved for Alzheimer's disease or other dementia? Number one, the drug is only approved for Alzheimer's dementia. And how do you know you're a good candidate? The the trials were really looking at people with mild Alzheimer's disease and even MCI with Alzheimer's disease and high amyloid burden on imaging studies. So to know that you're a good candidate for Aduhelm, number one, you would need to be sure that the diagnosis of Alzheimer's disease is what you have. You must rule out other disease, such as strokes can cause dementia, brain injury, medication. And so once that's done, and it's fairly convincing that you have Alzheimer's disease, and you would technically be a good candidate. However, in the trial I had mentioned, we had studied only mild MCI, mild Alzheimer's patient or people with mild cognitive impairment. So in my opinion, the drug would be most suited for people with early disease, possibly suited for people with moderate Alzheimer's dementia, but I'm not sure that it should be used in people with very advanced stages.
Thanks, Dr. Tai. I think another important aspect of this is that in the trials, to be enrolled in the study, we had to know that amyloid was present in the brain. You had to meet the criteria for early Alzheimer's disease, which was people with mild cognitive impairment or mild dementia. But we confirmed that amyloid was present in the brain. And so I know that some clinicians feel like they would only feel comfortable prescribing this drug when they know that amyloid is present in the brain. And that's who we know where the evidence really lies, is in patients who we know that the target of the drug is actually present there.
We have another question. Do I have to do a lumbar puncture to confirm amyloid? I think if you have a clinical picture, the right age group patients, have a history that is very typical of Alzheimer's. You have brain imaging studies that rule out other conditions. And if you can also get PET imaging, if you can get a PET amyloid, that's great. If you can sometime get a PET glucose that shows patterns most suggestive of Alzheimer's disease, then I don't think a spinal fluid would be needed.
Right. But it is true that currently it's difficult to get amyloid PET scans paid for, and we don't yet know how this approval will or will not impact those coverage decisions. And so certainly it's true that CSF is a way to determine if someone has abnormal levels of amyloid in all probability in their brain and might be appropriate for treatment with aducanumab.
And the next questions are important. What are the side effects of the drugs and weighing benefits and risks? So the most common, the serious side effects that we see in the clinical trial from our experience are two things, brain edema and microhemorrhage. The hemorrhage can occur inside the brain or on the covering of the brain. On the inside of the brain, we often refer as to just microhemorrhage. On the covering, we often refer to as superficial siderosis. These changes, edema and hemorrhage, are now referred to as ARIA. So you would see ARIA edema for swelling and ARIA H hemorrhage for bleeding. What are the chance of these things occurring? If you look at everything combined, then edema and hemorrhage occur in about 41% of all the subjects under higher dose. These tend to occur in the beginning when the medication is being titrated. That's why it's important to have brain MRI done after the 6 infusions early on. And what are the clinical side effects of these changes? The good news is with the edema, only about 27% of the patients have symptoms. The symptoms are mainly headache, dizziness. A small percentage of the patient do report visual changes, sensory symptoms. The good news from this is that people recover from these MRI changes that we see. Approximately 68% of the people with edema have a resolution of symptoms in about 12 weeks, and almost everyone, 98%, eventually have the symptoms resolved. So that's the good news for that.
Yeah, I totally agree. That's the good news. But monitoring patients who are taking aducanumab will be really important to make sure that they're still in good shape and not experiencing these side effects. That I totally agree with Dr. Tai. They're relatively frequent, 35 to 40%, mostly asymptomatic and mostly resolve with stopping the drug. They'll go away on their own, which is good, certainly good news.
So to help monitor that and to make sure people are getting the drug properly, the FDA prescribing guideline recommend a recent MRI within a year before treatment. I myself would recommend MRI closer to infusion, and that I would personally want something within 3 months, not a year ago. And you need to have an MRI again in 6 months before the 7th infusion, and likely another one in a year from the time you start. So those are the MRI monitoring. Some of the other questions that come in, I'm going to include. Will UCI do the infusion? Yes, we plan to start the infusion. Dr. Sajadi, my colleague, a specialist in dementia, will head off this effort. I would assist him. we have already submitted the protocol for the pharmacy here for review. The other questions that come in is about the cost. From Biogen's information, the wholesale cost is about $4,600 per month. That's the wholesale cost. We do not know what the cost would actually be once the pharmacy actually dispense that. And there's also a cost associated with the infusion itself. So there's that question. And then other question here is,
well, maybe just before we leave the cost, there were some questions about whether the cost is appropriate. So we don't yet know exactly how much this will cost, and we certainly don't yet know about coverage. And I think we can all expect that in the coming weeks to months, we'll hear a great deal more about this topic. It'll almost certainly be taken up by the Center for Medicaid and Medicare Services for a coverage evaluation decision. And I think those are going to be really important conversations. There was a quote offered by one of our viewers around whether the charge for a drug that hasn't yet been demonstrated to have clinical benefit is appropriate. And there's been much made in the headlines and in the peer-reviewed literature already about this. And this is an important consideration. One independent body reviewed the data available for aducanumab and arrived at a much lower cost. So I, for one, am very focused on understanding what the impact for families will be so that we know better how to have conversations about this treatment moving forward.
Yeah, some of the other comments I see coming in along the cost is, is it paid by Medicare? How much? That question is unknown at this point, so we don't know that. Another question is important to cover are patients on anticoagulants, not the candidates. So patients on anticoagulants are at risk for having hemorrhage. I'm not sure what to advise patient at this point. I think if you have a brain MRI prior to the infusion time and it didn't really show hemorrhage, then I think it would be probably safe to do if it's indicated to use Aduhelm, and then have repeat studies again within 6 months. In the clinical trial, if you have a lot of microhemorrhage, and a lot means 10 or more spots or 2 areas of superficial siderosis, the drugs will be discontinued. So that can probably be worked out with the treating neurologists and the patients, other doctors. The other question is, how long are we going to stay on treatment? We don't really have a lot of long-term data at this point. We do have data originally for 78 weeks. The EMBARK study, which is an extension study, is still ongoing. So hopefully we'll learn more about that.
Yeah, I think that's a really important topic that, as Dr. Tai points out, we don't have good data as yet. It's probably important to note that a few things. One, in the positive trial, the eMERGE trial, the benefit of the drug would seem to grow over time, and that if the drug works, the longer you take it, it may be that the bigger the benefit compared to untreated patients. But in the other trial, the drug didn't show efficacy, and so we're essentially cherry picking our data a bit, and I think that additional trial to confirm whether this drug works or not will be critical. But as Dr. Tai points out, we really don't know the long-term impact. If the drug works, how long does it work for? And what are the implications of taking it away too soon? I think another really important thing to communicate to families is that if this drug works, it works to slow things down a little bit. We don't expect that people who go on this therapy would experience a tremendous improvement in their cognitive performance or their performance in their daily lives. Instead, over time, we hope that this treatment or treatments like it can slow the progression of the disease and perhaps help them maintain their cognitive performance and their performance in their activities of daily living for a longer period of time. And again, the data to really help us understand the extent to which that will be true are largely limited at this point in time.
The next question I find very interesting and intriguing is Aduhelm approval anticipated to hinder or invigorate future research and treatment for AD? I think it's a great step forward. Maybe at this point, it's not the ideal monoclonal antibody that we should be using, but it would open us ways to do more studies, have a more refined and maybe direct approach to the treatment and help prevent the disease. So I think it's great news, actually.
And many people in the field believe that this could invigorate the industry side of research to invest more in Alzheimer's disease now that someone has shown that it's possible to get a drug approved. But there are others who feel differently. And I do think that there's a realistic possibility that this could make doing other trials more difficult. Certainly in the immediate future, we need to monitor the impact on trials that are ongoing and think about how to best design future studies. I think Dr. Tai and I agree. One thing is clear. We still need new and better treatments for this disease. If this drug works to slow the course of the disease, maybe it's a great first step, but we want drugs that can actually stop the disease in its tracks, make people better, prevent people from ever getting memory problems. And so there is still a great deal of work that needs to be done. But I think the opportunity to combine amyloid-lowering drugs with other mechanisms of treating this disease, which we know is very complex. At the very least, we'd love to have drugs that target both the plaques and the tangles, but much of the important work here at UCI focuses on neural inflammation and the role of other aspects of what's happening in the brain. And a cocktail approach to treating Alzheimer's disease may ultimately be necessary to develop true solutions. So hopefully this is a step on the bigger path to finding even more impactful treatment options.
To follow that up, there's a question: will clinical trials continue while the drug is available? Yes, it will. We do have clinical trials currently that involve patients without symptoms of Alzheimer's and yet have high amyloid or evidence of Alzheimer's on imagings alone. People in that trial will be informed of the availability of Aduhelm, and they can then make an informed decision whether or not to continue with the current study, which is a different agent, or try to leave the study and start Aduhelm. But I think it's very exciting with Aduhelm myself because it brings more immunotherapy treatment that have been used in other disease into Alzheimer's or neurodegenerative process.
But Aduhelm is not approved for people who don't have memory problems. So right now, the evidence is there to support this. If you believe the eMERGE trial, the evidence is there to support this in people who have mild cognitive impairment or mild dementia. There were some questions aligned with what Dr. Tai said earlier about moderate dementia. And there's just not an evidence base right now to support using the treatment in more moderate to severe stage patients. And I think especially given the risks associated with the drug and the possible costs to families, there's every reason to be cautious about who should and should not receive aducanumab.
One of the questions was, will Aduhelm improve cognitive performance and activities of daily living? And if so, how long before we should expect results? So that's where the treatment for Aduhelm in early AD and MCI came in. So the hope and expectation is their cognitive function can be preserved as long as possible. and the activities of daily living, particularly in patients with mild cognitive impairment, can be preserved as long as possible.
Yeah, and the trial data in the eMERGE study were based on an outcome measure that sort of involves both. It's called the Clinical Dementia Rating Scale, and it integrates examination of the patient, an interview with the caregiver, and the clinician's evaluation of the patient themselves. But in that one positive trial, the suggestion was that in some of the secondary analyses, there was also movement in the right direction, whereas in the other trial, these effects were not seen overall. So hopefully the phase 4 study will really lend to confidence in understanding the clinical benefit of the treatment if one exists, and exactly where that benefit is seen. Is it on the cognitive side, on the functional side, or hopefully on both sides? So there were some other questions about moderate dementia patients. I think we've already kind of addressed that. We're happy to see other questions. Let me toggle back and forth here. So Gabby, are there other types of patients that you think might be more or less appropriate? I've certainly heard some comments from colleagues about whether people who've had a stroke might be good candidates for this treatment, and some heightened sensitivity around folks with previous strokes, or considerations of people who are on blood thinners.
So the question about a patient with strokes, if we're sure that the dementia is mixed vascular dementia and Alzheimer's dementia, then it would be reasonable to consider treatment with Aduhelm. Sometimes patients I see sometimes are overdiagnosed with Alzheimer's when they have mainly vascular disease. In those cases, Aduhelm probably should not be used. In patients with very severe dementia, I do not think the drug should be used because the drug is not restorative. It does not give back what the patient has lost. So if you're in a very advanced stage, likely that would not be something that you should use for Aduhelm.
Another very good question came in. What's the latest on non-invasive biomarker testing for amyloid? And this is certainly an area extremely active in research. Nothing is quite ready for clinical practice yet, but the last year especially has seen some very prominent findings around blood biomarkers that ultimately may reach the clinic. I think the last year has been eye-opening and transformative in the area of blood biomarkers, and those do seem to be quite good at differentiating amyloid or Alzheimer's disease from other causes of cognitive impairment. And it's realistic now, I think, to imagine a day when blood tests could be a first step to identifying people who are appropriate for treatments like aducanumab, or even enrollment in prevention studies, for example. There's other interesting work happening around using MRI to try to predict amyloid outcomes, and I think much of this holds promise. And then I've seen some interesting data around just trying to change the way we do PET scans and reduce the amount of radiation associated with that, and still get the high integrity information around amyloid or other brain changes, depending on the PET marker you're using.
And I like to go back a bit to the PET amyloid. Sometime insurance plan, depending on which ones, can be convinced to approve the PET amyloid. But I wonder, with the approval of Aduhelm, will that change? Will the insurance company start to relax and allow patients to have the PET amyloid scan? So that's remains to be seen.
Yeah. And I think that's really important. And with a cost of $56,000 per year, once the anticipated maintenance dose has been achieved, as well as other costs, including possibly the cost of the PET scan and other imaging and et cetera. Again, I think this is something we're really going to have to stay on top of and understand how to talk to patients and families about this. And I think the one thing that I really hope doesn't come from this is that families who are already overburdened emotionally, physically, and financially, I would hate to see them incur a great deal of this cost themselves if they want to go on this therapy. Gabby, a great question for you, really important. Can this new drug be taken with others, such as Aricept? And maybe you can just kind of outline the other drugs that are approved really quickly for Alzheimer's disease. And then
yes, the other drugs that we have are essentially donepezil or Aricept for Alzheimer's, rivastigmine or Exelon, and we have memantine or Namenda approved for Alzheimer's disease. Yes, Aduhelm can be used with existing dementia medicine. The clinical trials did allow patients on donepezil and or memantine to be enrolled in the study.
And it's maybe important to say that none of the drugs mentioned are actually FDA approved for mild cognitive impairment, though those patients were enrolled in the trial. And memantine is not approved for moderate to severe dementia, though mild patients were also enrolled in the trial. So I think it was the right choice to not exclude patients in the Engage and Emerge trials, because we expect that aducanumab and other drugs like it work extremely differently compared to the drugs that are currently available. The drugs that are currently available are what we refer to as symptomatic therapies. When patients take them, their symptoms are a little better than if they weren't taking those drugs, but we don't believe that those drugs slow the course of the disease. Aducanumab, we know, directly targets the biology of the disease, the accumulation of these plaques in the brain. And for aducanumab has been convincingly shown to actually reduce or remove the plaques if the high enough dose of the drug is taken for long enough. So I think it was the right decision. And if aducanumab is effective and used clinically, no reason to need to prevent people who are already on those therapies from taking it as well. And I think it's fair to say no reason to expect any added challenges or safety risks from potential interactions between those types of drugs.
No.
Okay. Okay. Given the every time we run out of questions, someone comes through for us. Thank you to our audience for being here and for having these great questions. The next one is, given that the FDA approved Aduhelm based on being reasonably likely to be effective, are there other drugs in clinical trials that may be close to meeting the reasonably likely criteria? And actually, there were some headlines this morning that Eli Lilly intends to submit for a similar accelerated approval for another monoclonal antibody drug that has in clinical trials been shown to reduce amyloid burden in the brain. And aside from Eli Lilly's drug, there are at least two others that could conceivably follow in Lilly's and Biogen's footsteps and submit for accelerated approval. I think it's important to note that many in the field have reservations, to say the least, about this approach to the decision by the FDA to approve a drug without what has traditionally been the evidentiary standard for drug approval. That is, more than one trial that shows a clinical benefit of the treatment. So it'll be very interesting to see how the FDA handles these subsequent applications for approval through the accelerated pathway.
I will take the next question. My understanding is that LP or spinal tap is a less expensive way to test for amyloid? Is this a substitute for the PET scan? The spinal tap, yes, cost-wise, is less expensive than the PET scan. It is a more invasive procedure. It can be done safely, and we do that a lot ourselves. It does look at amyloid level in the spinal fluid. So yes, I agree that if you do not have PET amyloid, and if you want to make sure you have the right amyloid level before you take the Aduhelm, then the LP would be a good alternative.
And of course, the other powerful thing about CSF is that it gives us information about other things that are happening in the brain, including information about the neurofibrillary tangles that we consider the second hallmark of Alzheimer's disease, as well as information about brain injury in general. And those things are extremely valuable in the research setting. We have other clinical trials where we're really testing to see specifically if treatments can counteract the tau tangles or the brain injury that's associated with Alzheimer's disease. And for some of the treatments that are in development that target amyloid, there are hints that they may actually impact tau tangles as well. And again, many in the field believe that to truly slow or stop this disease, we might need to stop the progression of neurofibrillary tangles in the brain. And I think that's an extremely important and exciting aspect of these studies.
One question asked about the Eli Lilly monoclonal antibody. I think, Dr. Grill, you just covered that, right?
Yeah, I think it's asking specifically whether Eli Lilly's monoclonal antibody, which is called donanemab, has yet been tested in phase 3. My understanding is that the phase 3 trials of donanemab are now getting started. There was a very promising phase 2 study published in the last several months in the New England Journal of Medicine. UCI was a part of that study. And simultaneously, now it appears that Lilly is going to submit to the FDA for accelerated approval for donanemab. And we'd have to see what the impact on that phase 3 study would be. Perhaps it would just be converted into a phase 4 study. I have no insider information on that. I just saw the headline in this morning's paper.
So in the future, we may see different types of monoclonal antibody treatment available that may, that we can choose from.
Yeah, and that'll be very interesting. And clinicians like Dr. Tai will have to dig into the trial data to try to understand and distinguish these therapies. They do, the monoclonal antibodies do have differences. They target different aspects of the amyloid protein. We'll have to see if their safety profiles are largely similar or different. And we will learn from other fields. I know Dr. Tai is an expert in multiple sclerosis as well. And we've seen other therapeutic areas that have new treatments come much faster and more frequently than we've been able to do so for Alzheimer's disease. And we will try to learn about how to best adjust as new treatments become available and continue our pursuits of improvements.
I want to touch back on the stroke, hemorrhage, Aduhelm issues earlier. This medication, what it does, it removes the amyloid plaques. In the process, the blood vessels become more leaky, putting patients at risk for swelling and hemorrhage. And healthy people can also have microhemorrhage without treatment, with any amyloid treatment. And then we also find that patients with vascular disease or stroke patients are also at more risk for vascular disease and hemorrhage. So for patients with history of strokes, microhemorrhages on MRI, the decision to start Aduhelm have to be looked at very carefully to make sure you don't have a lot of microhemorrhages to begin with. And you may have go into a treatment with the side effects that's causing you neurological deficit that you were trying to prevent from not having a stroke to begin with.
Yeah, and one of the terms that people may see in the newspaper or other places to describe these possible side effects of aducanumab is ARIA, and I just want people to understand what we're talking about. ARIA, A-R-I-A, stands for amyloid-related imaging abnormalities. The term was actually born before aducanumab really entered into major clinical trials, because it does seem to be common to all the monoclonal antibodies, in particular those monoclonal antibodies at lower brain amyloid levels, as Dr. Tai was saying. And it was termed amyloid-related imaging abnormalities because of this phenomenon whereby they were seen on MRI, thankfully most often in the absence of symptoms. So people may see those terminologies, and clinicians may have to get quite used to them as use of these treatments begins. There's a question about the EXERT study, which is a study that was, is still ongoing and led by UCI's Dr. Carl Kottman, along with Dr. Laura Baker from Wake Forest. The pandemic made a lot of our studies more difficult, and certainly the EXERT study, where people were going to have get exercise through a personal trainer, was among those. That study is, as I understand it, near complete now and back up and running. So we're hopeful to have important answers to questions about exercise as a potential intervention for people with mild cognitive impairment in the coming months. And you can count on us doing a Ask the Doc to go over those results. There's another question about a drug in phase 2 from, I think, in a San Diego-based company, Cassava. I'm not particularly aware of the most recent results with that compound in phase 2, but we'll certainly keep an eye out for those. Gabby, there was a sort of question about whether whether CSF or PET was better for confirming the appropriateness of aducanumab. Maybe you want to offer more to that person from Houston?
Yes. For me, if I get to choose, I like to get the PET scan. It's not invasive. You do get injected with a tracer. It would show not just high amyloid deposits. It tells us where the deposits are also. But short of that, then the CSF amyloid studies would be fine.
And it's maybe important to add that there's strengths and limitations to both. I made note that with CSF we get information about amyloid and phosphorylated tau, which is related to the neurofibrillary tangles, and total tau, which is related to brain injury. There are other markers that look extremely promising for giving us additional information. But certainly, as Dr. Tai points out, the regional information that comes from PET is extremely valuable, and perhaps even more so when we think about trying to image the neurofibrillary tangles with PET imaging. And I particularly am excited about the potential value in clinical trials of PET tau to see if these drugs can, for example, slow or stop the spread of the neurofibrillary tangles, which seems to be much more closely related to the disease progression once a person has MCI and dementia in particular. So in the research setting, we often try to do as many of these things as possible because the information gleaned from each is so incredibly valuable to answering scientific questions. In clinical practice, it may be starkly different, I appreciate, but there is tremendous information coming from each of these various biomarker modalities. And we use biomarkers as a term to describe all of these biological measures of the disease.
So just to follow up on the PET scans that we use, essentially there are 3 types of PET scan that we do in dementia. The most commonly used, approved is the PET glucose. It looks at the metabolism. Generally, low metabolism in certain areas is more toward Alzheimer's, and sometimes it helps distinguish Alzheimer's from frontotemporal dementia, the way the brain's metabolize differently. And then we have the PET amyloid that shows high increase seen in, say, Alzheimer's. And as Dr. Grill had mentioned, we also have the PET tau that looks more at the tau deposits rather than the other components. Unfortunately, we can't combine these studies into one study, so we have to do them individually.
And all of the above are really quite valuable, I said, in research, but they're also each can be quite valuable in clinical practice, in particular for understanding in a person with cognitive problems and meeting criteria for dementia, whether Alzheimer's disease or some other neurodegenerative condition is the most likely contributor. And each of them differ in their particular value for those differential diagnoses. But again, I think the most important point is that the technology has come a long way in a short period of time, and the tools available to clinicians like Dr. Tai are greater now than they were even 5 years ago. And that's a sign of tremendous progress. Okay, we have about 10 minutes left in this session, and questions seem to have slowed. I can't see how many audience members we have, but if you have any more questions at this time, feel free to put them into your unique path to reach us. We're happy to take any or all questions. So, Dr. Tai, I mean, I do think one that we went over pretty quickly that's pretty tough is what can a person expect? Sorry, things went black for a second there. What can a person expect? What can their family expect when they start aducanumab treatment? They or their loved one starts aducanumab treatment. How would you talk through with a patient who is about to go on this therapy, what they might expect, what to look for?
For me, the very first thing is to make sure the drug is being used appropriately. Make sure this is for Alzheimer's disease. Do a MRI at beginning. Like I said earlier, I would prefer an MRI within 3 months' time. Going over that with the neurologist, make sure you know what abnormalities are pre-existing. Look for any microhemorrhages before you start therapy. So that's very important. And then the infusion would be given monthly. I would recommend having the infusion at a strong institutions so you can have a lot of support. I probably don't think you can have this treatment, at least in the beginning, through home health. You have to be monitored for the side effects. The infusion would run approximately 1 hour. We look for allergic reactions, swelling, nausea, vomiting. And then that would go on the titration would go on over the next 6 months. So you start out with, it's based by weight. So you start out with 1 milligram per kilogram. You do that for 2 months, and you go up to 3 milligram per kilogram for another 2 months, and you go to 6 milligram. So at the point of 6 months, like we said, the chance of the ARIA edema hemorrhage is higher because the amyloid plaques is being removed. So the blood vessels are leaky. So you would have to make sure you have another brain MRI again before going to the higher dose. between the 6 months treatment, between the initial and the next MRI, I would recommend being followed fairly closely by the neurologist who is giving you the Aduhelm. I strongly recommend having the infusion done by the same neurologist who's seeing you. Because otherwise, you would get infusion from someone and then you have side effects and there's change in your cognition. We don't know what your baseline is. So, what are the side effects that are concerning when the dose is titrating up? It would be typically headache, dizziness that we see. And then other things that are important, any focal changes, any change in your visual field. Are you weaker in one side or the other? That's new. You have new sensory symptoms. So those are main information that you need to watch out for. If you have those, you probably would need to contact the treating neurologist and probably need to get an MRI done if they think the deficit is severe enough, sooner rather than later. And then after that, let's just say everything was fine. And then at 6 months, you had another MRI, and then there's some swelling or there's some hemorrhage that's new. What to do, right? So in the clinical trial, if the side effects or the edema or the microhemorrhage are considered mild, and we have criteria for imaging what is mild, what is moderate, then the patient, if they have no symptoms, if they're very mild, they can go on to continue. If they have moderate changes on the MRI, then what we did was we hold the treatment, follow the patient clinically, do repeat MRI to see if there's any resolution, or at least stabilization, and then consider resuming the drug at a few months later. Exactly how many months, I don't know, because again, it depends on the person resolve or not. But if on the 6 months MRI, you see a lot of microhemorrhages, I'm talking more than 10 new ones, then I would recommend stopping the drugs and not going any further. Does that help answer a question?
Yeah, that was great. And we got a flurry of questions during that answer, which is also great. So really quick, there was a question about whether data are being collected internationally. The phase 3 trials were international, and some of the FDA analyses that were a little bit confusing included that there might have been different observations depending on which country's data was being examined. But I think that it'll be very interesting to see how other countries choose whether to follow the FDA's approach here. But we don't have any information on that as yet. There was a question about clarifying the potential benefits and what slow the progression implies. And I hope we did cover this. And I'll just say again, we don't expect people who start aducanumab to get better. What we're hoping is that if this drug works, it slows the worsening. And it may not be readily apparent to the patient themselves or their family members that the drug is working, because by working, we're really talking about a person getting less worse or worse more slowly, best case scenario, staying where they're at. And that would be a tremendous gain in our ability to treat this disease. A question, Gabby, about a person who's been having short-term memory problems or MCI for 5 years, knowing for sure that it's AD causing those memory problems. And again, I think those biomarker tests that Dr. Tai was describing, amyloid PET imaging, cerebrospinal fluid analysis for protein levels, those are the best tools available to clinicians to make a diagnosis with confidence that Alzheimer's disease is the cause of those short-term memory problems. And then last question was the potential impact of this new drug approval on studies into tau. And if the questioner meant tau therapies, then we really believe that those therapies need to be continued to be developed, and that it's possible someday we'll be able to treat the amyloid and the tau, we hope, with even better outcomes for patients. Gabby, I turn it over to you. Do you want to add to any of those quick lightning round answers?
I agree that the amyloid therapy is probably separate from the tau therapy, and hopefully we can continue to studies and maybe get combination therapy. Back to the question with the MCI for 5 years and only short term, that's also good news that have not progressed in 5 years. But if that's the question, then really more definitive studies would be recommended. MRI, brain, of course, amyloid PET, glucose PET, or spinal fluid would help answer those.
There was a last question on who to contact at UCI to set up an appointment to discuss Aduhelm. And again, I'm grateful to Dr. Tai on many levels for her leadership in UCI Mind, but also for being an outstanding clinician in the Department of Neurology at UCI Health. And that would be the right place to turn. The Department of Neurology at UCI Health is the place to turn for questions about treatment with Aduhelm from one of our outstanding clinicians.
And we will have another dementia specialist coming to the department later on this year, hopefully by September. Dr. Brian Hitt, he is a specialist in dementia. He'll be assisting Dr. Sajati, and he can help see patients and determine which is the best therapy.
I'm waiting for any last clicks, but otherwise I'm going to move toward closing the session. And once again, I want to, and I think we've put in the chat the phone number for calling the Department of Neurology at UCI Health. I want to especially thank Dr. Tai for taking time from her busy schedule to participate in this session with me. Greatly appreciated, Dr. Tai. Thank you for your outstanding work and for your informative Q&A today. I want to thank our members of our community for joining this session. We hope it was helpful. These are interesting and important times in the field of Alzheimer's disease research. It is extremely exciting to see progress being made, and we are eager to continue the good work of discovering better options for families dealing with these diseases. Before I close, I'll just remind you that this session and our other Ask the Doc and similar types of sessions are available on the UCI Mind website, and in particular on the Mindcast page of the UCI Mind website. We do effort to have lots of information available to people who are interested in Alzheimer's disease research, and also to have resources for families and for even practitioners who are looking for more. We will have additional sessions coming this summer and into the fall. We are eager to resume our in-person outreach activities and hope to be able to do that soon. I'm thrilled to report that UCI anticipates a return to full in-person activities for the fall quarter. I, for one, am extremely excited about that, and excited to get back into the community, to bring our education and expertise to our friends throughout Orange County. Research made this progress possible. And if you're interested in participating in research, we would urge you to consider enrolling in our C2C Consent to Contact Registry, so that if there might be a study that needs you, we can let you know about that study, and you can decide if you wish to participate in it. It's free, confidential, and completely voluntary. So if you're interested in helping make the next tremendous research discovery, think about enrolling in C2C. With that, Dr. Tai, thank you again. Thanks to everyone for joining today. We'll see you again, I believe, in August for our next Ask the Doc session on UCI Mindcast. Take care.
Bye-bye.